Here is an overview of our presentation about cleft lip and cleft lip with cleft palate and psychological functioning. First, we will discuss background information about the condition of cleft lip and cleft palate and associated psychological impairments. Then, we will discuss our research questions, the importance of our topics, and the 3 articles we wrote about in our literature reviews, followed by our references.
Okay, so now I will be talking about some background information dealing with cleft lip and cleft palate. Cleft repairs start early in life. About 10 weeks old is when a baby will have their first surgery for their cleft. Treatment often involves a series of surgeries, so it's not just one, and they can continue throughout life. Children born with clefts will often also have dental problems as well as jaw problems that will be fixed when they reach adolescence. So as you can see, it's a lifelong condition that can have impacts even though the cleft itself might be fixed. A lot of the articles we looked at talked about how it's very important for cleft patients to be managed by a multidisciplinary team, including surgeons, pediatricians, psychiatrists, counselors, and also the speech-language pathologist, which is a big one. Because patients with cleft can have speech difficulties, they can have problems with resonance, hypernasality is a big one, and feeding issues, all of which we deal with as SLPs. And children born with cleft lip or palate have also been shown to have an increased risk for psychosocial deficits, which can be a big issue as they grow into adolescence, and which is what we will talk about in this presentation.
This slide shows our research questions, which we will assess through an observational study in the form of a survey. They include, do adolescents with cleft lip and cleft palate experience difficulty with psychological functioning? And how does the amount of therapy received, psychological and speech therapy, influence these issues in this population? This topic is important because infants born with cleft lip and cleft palate are at an increased risk for psychosocial difficulties compared to their typically developing peers. It is important for us as clinicians to understand the psychological implications when working with these individuals to improve their quality of life. It is important to consider these implications when designing and implementing intervention plans, and it is important for all the members of the intervention team to consider when playing their part.
So the first study we'll be talking about is entitled Development and Validation of the Quality of Life Adolescent Cleft Questionnaire in Patients with Cleft Lip and Palate by Pambino et al. And the only reason I knew how to say that author's last name is because Talia helped me. This study came out of Italy. And it focuses around these researchers who are looking to develop a questionnaire that would adequately measure quality of life in adolescents with cleft lip and palate for adolescents in Italy. It was a very interesting study. When they were developing their questionnaire, they subcategorized quality of life into 3 categories, including physical health, which had a lot of speech-related questions, so like questions about nasal regurgitation, those types of things, social health, and psychological health. Their sample size was 40 Italian adolescents from different areas in Italy, all ages 16 to 24, with repaired clefts, and they had them take the questionnaire they made, and then they compared the results to the results of 40 Italian adolescents without clefts to look at whether or not there were any disparities in the 3 areas of health that they measured with their questionnaire. Another criteria that was very interesting with choosing the experimental group in this study was that they were purposely looking for adolescents who did not have their surgical recovery managed by a multidisciplinary team. I think something like 72% of participants in the experimental group said they did not receive any psychological support following cleft repair, and I thought that was interesting. And then this next slide just shows some of the major findings from their study. Basically, the researchers found that adolescents in Cleft in general had lower self-esteem and social skills than the control group. To kind of break that down, 42.4% of adolescents surveyed reported being bullied at some point in their lives versus only 10% of the control group who said they had experienced bullying. In terms of social situations, adolescents with Cleft tended to isolate themselves in social situations. I think like 57% of them did this before they finished surgery. 27.5% of the adolescents with Cleft surveyed said they had problems in relationships with their peers. You can contrast that to the 12.5% of the control group who said they had problems in relationships with their peers. Depression was an issue among some of these patients, as was anxiety related to their health. And then below that statistic I pointed out earlier, just saying that 72% of the patients with Cleft surveyed reported not receiving psychological support. And an interesting but maybe more obvious finding from the study was that many of the patients surveyed with Clefts reported dissatisfaction with how they looked, and mainly focusing on how their face and their oral cavity looked. And only 17.5% of the patients who the study surveyed said they did not think they needed further surgery to help correct their appearance. Okay, so this slide just talks about the strengths and weaknesses of the study. The study had several strengths. It had very strict criteria for Cleft participants. The adolescents they surveyed could not have any other issues besides Cleft Palate, so no other genetic syndromes, no intellectual disability, nothing, just typically developing, but had a cleft lip or palate. The study did a good job of equally matching the control and experimental group. What I mean by that is they really tried for every experimental subject. They tried to have a control subject who looked just like them in terms of like age and sex and geographic location in Italy. To a certain extent, they randomly selected the experimental group participants, and the study had a very equal number of male and females involved. I think there was only like a 2-person difference between the two sexes represented. Weaknesses, something I found with the studies I looked at was that the sample size was small. They only had 40 participants who they had surveys that were detailed enough that they could use. And they had 40 in the control group too, since they had 40 in the experimental group. And what I thought was interesting was that this study got their control participants from a clinic, a dental clinic. So all the people in the control group had malocclusion. They had been treated for malocclusion. So it kind of makes you wonder how typical the control group was if they had dental problems. But an interesting way to choose participants.
The next study we'll be talking about is called The Effect of Cleft Lip on Socio-Emotional Functioning in School-Aged Children by Murray et al. It was published in 2010. This is a cross-sectional observational study. It was designed to assess the socio-emotional functioning in children with cleft lip and cleft palate compared to a normal control group. This study included 98 individuals with cleft lip and or cleft palate and 77 typical developing peers. All of the children included in the study were age 7. The assessments used included teacher reports, maternal reports, direct observations, and the children's own accounts about their socio-emotional functioning. The teachers and mothers completed the child behavior checklist to assess for anxious, depressed, withdrawn, depressed, and social problems. The researchers observed the children on the playground for 30-minute sessions to assess their social interactions with their peers. The children's own accounts were assessed through the pictorial scale of perceived competence and social acceptance for young children, and a doll play task in which the child was asked to role-play social scenarios. The results of the study showed that children with clefts are more likely to spend time alone and away from group play and to experience negative interactions with their peers. The questionnaires from the teachers and the parents and the direct observations by the researchers revealed elevated rates of anxious and withdrawn depressed behaviors in the children with clefts, and also difficulties with social relationships in the children with clefts compared to their typically developing control group. The article by Murray et al. Had several strengths, including the very large sample size, the age and sex-matched control group of typically developing peers to the children with cleft lip and cleft palate. The study also had a comprehensive battery of assessments for socio-emotional functioning, which included standardized questionnaires, direct observations, and child representations. Children with other conditions other than cleft lip and cleft palate in both the control group and the cleft group were excluded from the study in case of any confounding effects. Also, all of the children in the study came from similar, secure parenting environments. Weaknesses of the study by Murray et al. Included the fact that there were a limited number of variations of cleft lip and cleft palate versus cleft lip only. Also, psychologists could not always be blind to the cleft versus control group because even though all the children in the cleft group had already had the surgery to repair their cleft lip, the scar was often evident, and so the psychologist could tell which children had had the surgery. The findings of this study must be replicated because of the comprehensive amount of assessments that were utilized. The last study we will address is called Parent Reports of the Psychosocial Functioning of Children with Cleft Lip and or Palate by Hunt et al. From 2007. This is another cross-sectional observational study. This one assesses only parental opinions about psychosocial functioning of children with cleft lip and or palate compared to their typically developing peers. This study included 129 children with cleft lip and palate and 96 children for the control group without cleft lip and palate. In this study, parents were asked to report on their children's mental health. They used the visual analog scales, which assessed self-esteem, happiness, appearance satisfaction, current anxiety levels, general anxiety, and other problems related to facial appearance. They also filled out the child behavior checklist, which assessed internalizing and externalizing behaviors in addition to a total behavior scale. The last part of the study was an interview with the researchers, which consisted of yes and no questions and short answer questions about bullying, appearance, and speech satisfaction. Parents of children with cleft lip and palate described their children as more anxious and unhappy compared to the typically developing control group. The children with clefts seemed to develop more problems related to their facial appearance and were overall less satisfied with their facial appearance. The parents of the cleft lip and palate group also reported more behavioral problems and externalizing behaviors than those of the parents in the control group. The strengths of the article by Hunt et al. Was the very large sample size. Another strength was the various amounts of assessments that they used, which gave a comprehensive overview of the parental opinions of their children's emotions. They also excluded children with other medical conditions, and they also excluded children with learning disabilities in case of any confounding variables. Some weaknesses of the study were related to the fact that they relied on parent reports about their children's emotional functioning. Parent mental health is a possible confounding variable. The mental health of the parent could affect how they report about their own children. In addition, a parent could be biased about their own child, either underreporting mental health issues or overreporting mental health issues.